to Psychiatry Grand Rounds. As a reminder, if you are a medical student, psychiatry resident, or an attending who would like to register for attendance or CME credit, please call 423-200-3259 and enter the event code 26013. This information is posted in the lobby. The Grand Rounds Committee would also like to request that you silence your cell phones and refrain from unnecessary use during the presentation. This morning, I have the pleasure of introducing Dr. Kamran Hayel and Dr. Stephen Smith. Dr. Smith completed his psychiatry doctorate at Wright State University School of Professional Psychology, and he completed his internship at the Mountain Home VA Medical Center, where he is currently working. Dr. Hayel Okay, I apologize. He's currently working at Team Health. Dr. Kamran Hayel completed his medical school education at, you're going to have to help me with the name of the school.
Categorical.
Faculty of Medicine in Iran. He is currently the Chief of Inpatient Psychiatry Services at the Mountain Home VA and Assistant Professor at East Tennessee State University, where he also completed his psychiatry residency. Please welcome Dr. Hayel and Dr. Smith.
Well, thank you for the introduction here. The subject today, before we started, I have to do the disclosure, which beside the working in a VA, I don't get money from anywhere else. And the old saying that if you find any place that they can pay me, you're welcome to let me know on that regard. The question today was, is malingering a psychiatric diagnosis? And in order to answer this question, I don't know if this presentation would help you to find the answer or not, but I just want to make a question in everybody's mind. So we think about the malingering, sometimes we get that gut feeling. I'm sure that the attendings and the residents that they are present here and the psychologists that they are working in a field of the mental health, once in a while you get a patient that you feel, your gut feeling is telling you that there is something wrong with this picture. And it crosses your mind that maybe there is something going on beside what they are presenting with. And sometimes malingering comes to your mind. So before we jump on a conclusion about the diagnosis, we'll see what we have. I just collected a few cases that we have seen, and it's an actual case that I have seen, and I put it on the first slides for you to think about it. And I would like for you guys, without any jumping on a conclusion on these cases, just read the story of these patients. As a 38-year-old white divorced male that lives with the girlfriend, comes to the ER. He's intoxicated. It's a cold night. It's 5 degrees outside. Multiple hospitalization. Most recent one was 2 weeks ago. And he has a suicidal ideation. When you ask about the plan, he gives you something, but it's not a clear plan. For example, I had one patient that when I asked him, what is your plan? He says, I had a plan to choke myself. And he put his hands like this. So I informed him later on that if you want to choke yourself like this, you will be unconscious before you die, and then your hands would, loosen, and you won't be able to kill yourself like this. Maybe I did the wrong thing to tell him. But previous diagnosis of the depression, substance dependency and use, and bipolar disorder. And those are in different, encounter that he saw different people with this diagnosis. Now, I'm not implying that this gentleman was malingering. Second case, 51 years old, black divorced male, homeless, comes to the ER, UDS is positive for cocaine, multiple hospitalization. A month ago, he was in a hospital. He's also, poor guy, is banned from all the shelters in 100 miles radius. So he's homeless, but he cannot go to the shelter. You can only imagine what causes the patient to be banned from the shelters. Now, he's also getting a paycheck every month, but this month money is gone, and he has to wait until the next month paycheck to come, either on disability or service connection or something like this. So when we encounter a patient that will give a question to our mind that what is the actual reason that the patient comes to see us, we also have to have a knowledge about any other picture of the disease that comes, and it may present itself a little bit unusual, and you don't have enough evidence to make a diagnosis about the Axis 1 in the past, and DSM-5 referred to the diagnosis. So I put together a few of those diagnoses that usually is around the same thing that the malingering also will come with it. They are different from malingering in different ways. For example, factitious disorder. Won't you like the APA that every once in a while they change the name of the diagnosis that we used to for 10 years, 11 years, and they come with a new name? Conversion disorder now is called functional neurological symptom disorder. So we have to switch from the conversion to this new name. Somatic symptom disorder. Illness anxiety disorder is a new one in the DSM-5 that we didn't have too much equal to it in the past, and we'll talk about that one. There is some other diagnosis like dissociative disorder. You may got a little bit of the picture of the antisocial personalities in one of those cases that we were presenting. And also there is a new diagnosis of the psychological factor affecting other medical conditions. So looking at the picture, when someone comes into you always have in your mind that, am I dealing with the true presentation of the case, or is something that else is going on? Now, there are some definition of the word that we need to clear it. Feigning means that to present falsely in order to deceive. But there is no external incentive on that. So it's not equal to the malingering. Malingering does require feigning, but it does also require the external incentive. Now this sentence down here, kind of liked it, because it does compare the feigning to the malingering, same as the detection to the diagnosis. And I coded there. Now, what is the malingering? According to the Oxford Dictionary, pretending to be ill in order to escape duty and work, or work. So that's Oxford. Now, but it's not as simple as it is. Certainly it has to be intentional. It has to be a false or exaggerated symptoms. It has to have some motivation behind it. It has to have an external incentive. And when you look at all this criteria that is required for the malingering, it's not that much easy to find, because you are not a mind reader. You cannot look at the patient and read their mind to see what is behind it. So there are lots of other stuff needs to be taking place in order to make that definite diagnosis. But it's mainly in a compensation setting. You will see it in seeking drugs, those illicit drugs that it comes, and also the pills that we can prescribe as a physician. And so we have to be careful about someone whose external incentive is to get the Lortab, for example, or benzodiazepine, for example. We will see it a lot in people that they want to avoid the military duty. So that's also sometimes, it's not that much easy for people to go and fight. And they just want to, or go to those training that is very hard. So they will try to avoid those training. and we will see that one. And as usual, anybody blows anywhere or kills anyone, you will see in the news that some of those lawyers wants to attach it to the mental illness. It's good and bad. Good because we pay more attention to the mental illness. They may give us a little bit more funding to teach people, and there is going to be a little bit of the more, help for the educational facility. But it's bad in one way, that anybody thinks that if you have a mental illness, you are a criminal too. So that's also a negative, effect of when something bad happens and someone kills someone, or so someone blows somewhere, all of a sudden we hear in the news that they are evaluating the person to see if he has mental illness or not. And unfortunately, later on, they won't give a news that after evaluation, that person was found not being mentally ill. So we don't pay attention to that one. So genuine malingering is a gross, this part is very important, gross exaggeration of the symptoms, and it's a conscious effort to deceive you. Now, I found this one interesting. Malingering is a V code. Now, maybe some people don't know about the V code. V code is in healthcare informatics, is assignment of a numeric code used for the visits to the healthcare professional for purpose other than for sickness. So, for example, if I go every year to see my primary care for my annual physical, I will get a V code when they are coding it for the insurance. So malingering also is part of that. For example, immunization is not a disease, but you go to the professional to get that one done. That's a V code. Pregnancy is not a disease, but you see your gynecologist every month in order to get that one. So when we come to the malingering, it's a V code. So mainly in a legal context, we will see this diagnosis comes up. And almost any illness that relies on a self-report can be feigned. So in psychiatry, sometimes we still rely on our physical exam, we rely on our interview, and we rely to the information that the patient provides to us. So one of the branch of the medicine that we still need the clinical skill is psychiatry. So we have to be careful and we have to be more skilled in order to find the true diagnosis on a patient. Any other field of the medicine right now, if you enter to the doctor's office, first you have to go to the lab and go CT scan and all those, fancy things done in order for the doctor to make an exam on you. I have been a victim of that myself. I took my daughter to the JCMC for a pain in this area, and after 8 hours of doing all those labs and everything, and $8,000 worth of the workup, finally I saw the ER physician came and evaluated the patient. So it's changing. We rely more in other field of the medicine on a paraclinic than the clinic. But in psychiatry, good thing is you still have to have a clinical skill in order to do that. So one of the things that sometimes you see the people try to malinger is a psychosis. Now, how do we recognize if the person doesn't see or hear anything that they are reporting to you? There are a few things that you can pay attention to it. For example, hallucination is not continuous hallucination. So someone doesn't hallucinate 24/7. So that's one thing that you can, trying to, in your skill of the interview, to find out how often they do have this hallucination, what kind of things And the hallucination is not vague. It's kind of clear. You will find the hallucination pretty much, present itself because the patient either see or hear things, and they can explain what's going on with it. Hallucination, sometimes they report that it's not associated with the delusions. Inability to state strategies to diminish voices. Now, if someone is hearing voices and that voice bothers them, reality is you try to diminish that. Sometimes they say, when I have these voices and I ask them that, how do you try to get rid of it? And they will say, I hum, and that will go away. Or I listen to the music. I try to, get a little bit busy, watch the TV, or do something that voice goes away. They try to diminish it if it does bother them. So it's not something that you sit down and listen to that voices that you don't see any sources for it and try to do that. A report that all command hallucination are obeyed is not usual. So you don't follow the order of everything that you hallucinate. So that's something to keep in mind. If the delusion happen in someone, it's not an abrupt onset. Onset is usually gradual. So if someone comes and says, all these things happened, started yesterday, and I have all this stuff going on, we are thinking about something else maybe is behind it. Patient has an eagerness to call attention to the delusion. So we had some people that they've been dealing with the hallucination for a long period of time, and they never even talk to the closest people to them. So you look at the picture, if someone comes in and they start having this delusion or hallucination, and they try to get your attention to it, and they had it for a short period of time, and there is a little bit of the question about if it's a truth behind it. But none of them is 100%. I mean, your picture is not going to be, if one of these happened, then that guy is faking it. Behavior is very important if it's inconsistent with the reported delusion. And someone who has a bizarre delusion or bizarre hallucination, and they do not have a thinking or speech that it's disordered or disappropriate, then you will have a question about it. If I'm thinking about the alien came and abducted me and they placed the chips in my head, then my thinking is delusional. It should be some kind of the inappropriate thinking or speech included on my behavior. So that's something to keep in mind. Now, another thing that can be kind of malingered is neurocognitive impairment for any reason. So I found this YouTube, and I will play this one and hopefully shows up.
Hey, there's Leo.
Oh, who's Leo?
Uncle Leo.
Oh, yeah, right. Uncle Leo. Forgot his first name.
Did I just see that?
Well, that ought to keep you busy for a couple of days, huh?
Jerry, hello.
So, Leo, how's everything? You doing okay?
I still have the ringing in the ears. Sounds like the phone.
Yeah, but what about money? Are you strapped? Do you need a little?
Are you kidding? I should be loaning you money. But I'm not.
Leo, I saw you in Brentano's yesterday.
Why don't you say hello?
Because you were too busy stealing a book.
You still say hello?
Oh, I saw you steal.
Oh, they don't care. We all do it.
Who? Criminals?
Senior citizens. No big deal.
You could get arrested.
Arrested? Come on! I'm an old man. I'm confused. I thought I paid for it. What's my name? Could you take me home? All right, Mr. Goody Two-Shoes. You made your point.
Thank you.
Will somebody answer that damn phone?
I don't believe this. Excuse me, I wonder if you could do me a favor. My uncle's having a little problem with shoplifting.
Mm-hmm. Where's your uncle?
He's over there in the overcoat. If you could just kind of put a scare into him, you know, set him straight.
We have a 5150 in paperbacks. All units respond.
5150, that's just a scare,
Sir,
right?
I'm going to have to ask you to stand out of the way and let us handle this. Swarm! Swarm!
What? I'm an old man. I'm confused.
You're under arrest.
I just wanted you to scare him.
Jerry, you right.
Back to the slides. PowerPoint. Which one is it? Anyway, but that's that was a clip about the neurocognitive. I think it would explain better than I can. There's a sometimes, you know, they will get some benefit from the having a cognitive impairment, but I haven't seen too many of the cases. But usually, typically, is absence of the functioning. So you do not have too much of the functioning that was done. It's the absence of some functioning that you can recognize. Another one that is really hard to find out about if the patient is malingering is PTSD. If you look at the things that is important to make a diagnosis of the PTSD, it's first trauma. So who are you to say that trauma didn't take place when the patient reports to you? There are some places that, for example, you are working in a VA and the patient comes in and says, yes, he was in Iraq and Afghanistan and got this trauma, and then you look at the DOD report and you find out that this patient never been, you know, deployed. Yeah, that's sometimes, you know, you can find out about it, but not always. So the trauma takes place, you can't do anything. And intrusive, distressing memories, how can you, you know, really recognize if the memory doesn't come back on that situation? Recurrent distressing, dissociative reaction, flashback. How many times you have heard of the patient that they are reporting that they have a flashback? Many times. Sometimes the flashback is also misunderstanding of what is the meaning of the flashback when you ask the patient. They recall that thinking about those memory of the event that took place, sometimes they recall that one as a flashback, which is not, but they usually, we have to explain for the patient what the flashback is before we get the right answer on that. The only part that in PTSD that we would be able to observe is that red part, marked physiological reaction. So if someone is walking here and I'm showing this slide and all of a sudden that sound effect will cause them to jump or cause them to get, you know, heart racing, or their blood pressure goes up, they get sweaty. So you do have something that sound effect that I put it on the slide, unfortunately, will cause that patient to have a bad memory or a flashback or reflection to that, the same thing that they were hearing in the past. So that's a part that is very important for someone who does the interview to look at when they are talking about the memory, what is the reaction? What is their, change of the facial expression? So you do have a kind of, opportunity to look at it. But if someone doesn't have a marked physiological reaction in front of me, still, based on the DSM-5, and meets the other criteria, 1 is enough. So you don't have to have that physiological reaction. So if you have intrusive, distressing memories that you reported to me, that's enough for the diagnosis. So that's something hard to make a diagnosis and make a statement that maybe is something that malingered. External incentive, medical legal context, lack of cooperation of the patient is important, and then if anything that is not matching with the objective finding. Now, factitious disorder, oops, went back again. I'm sorry, I think up. Don't send. Thank you. What did I do wrong? Factitious disorder, as you see, falsification of the physical or psychological signs and symptoms, that the motivation is only be sick. So if someone comes in and they just want to be sick, and that's why they are falsifying the information, that's a factitious disorder. It's not a malingering. So conversion disorder, or that new name that we have for it, which is functional neurological symptom disorder. Weakness, paralysis, abnormal movement like tremor, dystonic movement, can be attack of the seizure, that can be, as a result of the conversion disorder. And the conversion disorder, the patient doesn't have a conscious effort to make that symptoms. But you can't find anything wrong with them. There is a term, they call it labella indifferens, and that was mainly coined because they thought that people with the conversion disorder, they are not as concerned about their lack of the problem that they have. Like if someone has a seizure, but they are not too much concerned about it. That's called labella indifferens. But the lack of labella indifferens, it does not rule out the conversion disorder. And certainly the Freud made that conversion disorder as a coining that diagnosis, but then right now we know that not everything that he was thinking that was supposed to be included in a conversion disorder exists anymore. This psychological factor affecting other medical condition, for example, if someone is anxious and their anxiety aggravates their asthma, that's a diagnosis that comes on board, for example. So if there is a medical condition exists, and then there is a psychological problem that exists, and that psychological problem causes the medical problem to get worse. And then illness anxiety disorder, I found this quote very interesting. Grief that finds no vent in tears makes other organs weep. So if someone is having constant thought of being sick, but they don't go to the doctor, they know somewhere in their unconscious level that they are not really sick, but they have this anxiety of being sick. So they can have an illness anxiety disorder. And the somatic symptoms disorder, certainly you can find this information in a DSM-5. That's another diagnosis that really comes on mind when we have the patient with the not matching the symptoms with the objective finding. We need to rule out this one. And putting it together, all of them together, for this conversion disorder, there's no intentional feigning of symptoms. Incentive is not there. Factitious does have an intentional feigning, but only to be sick. And illness anxiety don't have an intentional, and there's no incentive. Somatic symptoms, also the same. Malingering does have an intentional feigning, and also there is external incentive. So, and that is why we are not having a national health care, because the malingering would be a crime. And this is a cost that malingering sometimes causes to happen. At minimum, $68 billion annually is wasted, the cost of the care for the anti-fraud. So, and highest number that they had at least 10%. We are talking about 230 billion. And things that we can do as a clinician, if you observe someone for a long time, feigning as symptoms for a long period of time is a hard thing to do. So you need to observe for a long time in order to find out. And I need to escape a little bit on this slides, just the timing part. So always be cautious about the reaching conclusion of the malingering. If you are sure, make sure your documentation is covering you for that particular thing, and everything that you observe is documented. And the persons that malingers the psychotic disorder, we talk about this one, it's always exaggerated hallucination, and they cannot feign the blunted affect and the concrete thinking, and they sometimes they make a mistake if we don't educate them that the dense amnesia or disorientation is the future of the psychosis, which is not. And this is drug and shelter. I just want to give enough time for Dr. Smith to talk about those tests that we have. So I'll go through these slides, and you do have access to this slide by going to the ETSU, and it's self-explanatory. Now I want to talk about this one, iatrogenic malingering. We teach our patients sometimes, we are guilty, that if you don't have any place to go, and you need to be in a hospital because that's the only place that you can find, then you need to be suicidal, because you don't meet the criteria if you are not suicidal. And unfortunately, that is the lack of the access to the other options in this country. It's a big country, we have lots of money, but we don't spend enough money to provide those alternatives. It's cold outside. I am, feeling down and depressed, homeless. I don't have enough money. I use the drugs that makes me depressed, and all those stuff. I'm depressed, but I may not have a real plan to kill myself or die. But I know if I go to the ER and I don't say I'm suicidal, I don't meet the criteria. So we teach our patients. This is a term that I came on with, but I don't see it anywhere else. I think that we need to think about it. We need to have some place for the patient to get what they need in order to not occupying the beds in a hospital, which is expensive. So we pay more money to keep a patient in a hospital every night, average between $1,000 to $2,000 every night, cost of the caring the patient in a hospital. Then we have 2 shelters in Johnson City. One is Heaven of Mercy, and the other one is Salvation Army. They have a very limited, and it's not very good quality, of course, but thanks that we have that place. And sometimes patient is not qualified to go there. So we don't think about it. So this is something that I hope that we as a people that they are working in a professional healthcare, we be able to convince those people that they are able to provide more funding for this stuff. There are some psychological testing that I'm not going to talk about it because Dr. Smith is the expert on that one, and I'm going to give the microphone to Dr. Smith. Thanks.
Oh, can you hear me okay? No, there we go. I feel kind of sick. I think maybe you should take over. No, okay. That's not malingering. One of the things, yes, I'm not anticipating any financial gains from this. If there were, I would have signed up sooner. And it's something that I think keeps it clean, though, actually. One of the things he was mentioning a minute ago, a lot of things come up for me when I talk about this particular topic. And some of it includes not just us as professionals, but the paraprofessionals that we work with. They don't use the term malingering quite often. They say they're FOS, or they are faking it, or they're BSing, and all kinds of things. And it often falls on our shoulders to try to be the person or the agent to kind of create a learning situation for people around us. Because often, like you were talking about a second ago, when people are malingering, there can be all kinds of reasons why they're doing that. And sometimes, you said a second ago as well, and I think very appropriately, unless it's just overwhelming, you put that in the record and it takes on a life all of its own. And what I mean by that, I've seen people come in and do I can't get into shelters, but I'm suicidal, and they go into the hospital, and then they come back and they have an injury, a real injury, and they're like, well, they're a malingerer. And it starts to affect other parts of their care. And that's part of the carefulness that we have to have when we approach the topic. It also brings up a lot of emotion in people, I've noticed over the years. And I'll talk about that some in a minute, but I've seen a person who's suspected of malingering split multidisciplinary teams. Split them up and not even be really intending to do it. But they'll feel that. The patient will eventually feel it. And it can be quite destructive to their care. And so being able to successfully create a situation, and that's the beauty of the testing, really, where you can inform the team about what you have informationally through objective testing. Then it becomes a much more powerful case and provides more options on how to approach treating somebody. And that should be our goal, is how do we reach to this person and treat them and provide the best care possible. And that's how you can do that. So, excuse me, one of the things that this talks about is, Barry and Nelson suggested there's 3 problems with the Diagnostic and Statistical Manual for Mental Disorders. And part of what they talk about, they go back to the DSM-3, 4, and 5. It says it's categorical when it should be dimensional. It relies on judgments of character as opposed to looking at the function behind reported symptoms. I'll come back to that one in just a second. And the criteria for malingering has not changed significantly since the DSM-3, even though the research has increased and understanding of it have increased dramatically. Now, if we look at a categorical versus dimensional approach, what we're looking at is checking a box if somebody meets a certain criteria versus looking at what the function of that behavior is. What are all the things that are playing a role in somebody coming forward and trying to essentially fake an illness of some type. The DSM conceptual model for malingering has been criticized from other perspectives as well, surveying the criteria noted above, whose presence was supposed to increase suspicion of the presence of malingering. So Rogers argued that not only integrating, the only integrating theme was the badness or criminological model of this. And this is what I'm talking about. We start making it an issue of a person's character as trying to look at what the function of the behavior might be. And this goes all the way back to my roots as a functional behavioral analyst of autistic kids and kids who have all sorts of problems as far as brain injury and that type of thing. I had a kid one time who just had a very significantly impaired with autism, and which, you know, primary in that is poor social skills. And a teacher was telling me about this kid, and she says, he's just an asshole. And I said, tell me what you mean by that. So's, you know, my dad. No, I'm just kidding. My dad was a sweet guy. I'm kidding. But tell me what you mean by that. And she said, I'm standing here one day. I got bad information. I got some information about a person in my life that was in an accident. And I was crying, and he just walks up and gets between the two of us and says, you know, when are you going to take us outside? And she said he has absolutely, he didn't care about anybody but himself. And it's when we start making characterological jumps as opposed to looking at functions and symptoms that you can actually make the true problem worse. We know that negative emotional expressiveness, for example, in people with schizophrenia can make their schizophrenic symptoms worse. We know that people who have depression, and you make characterological judgments, lazy, unmotivated, those kinds of things, it can make the depression worse. And so if somebody's using this as a coping strategy, and we make it less about character or less about them trying to get one over on us, I think it makes us better as clinicians as getting to the root problem when we don't personalize it. Does that make sense? Yeah. So Rogers suggested the DSM criteria essentially characterizes the malingerer as a bad person, antisocial personality disorder, possibly borderline personality disorder, in bad circumstances, legal difficulties, doing bad things, uncooperative with evaluation and treatment. Unlike other diagnoses, this conception of malingering seems less related to a description of distinct symptoms, behaviors, more prescriptions of one's character. So I thought, let me just put this into a search engine and see what comes up. I'll put malingering in and then see what images come up for malingering. That was the first one. Some perjury going on. Puppy dog eyes. Now see, that's antisocial right there. People that can look at you like that, they're going to get the whole world over on us, is what it is. So, adversarial versus personalized. Is this what drives much of the negativity towards a malingering patient? Making moral judgments. They're lying. Personal judgments. They won't get one over on me. I get that one a lot from paraprofessionals. I've had paraprofessionals approach me and go, you know, because I'm meeting the person where they're at, and I'm listening to the symptoms, and even if I suspect that they might be malingering, I'm often looking at the situation going, so what would be the function of this? What would be causing this person to do? Are they just, truly, some antisocials appreciate the sort of micro lies, the ways just to lie to people to have power over the situation. But how can I provide more choice, which may equal power, to reduce them doing that to fake out an entire healthcare system? So there's ways to come about that relies on our education and our ability to do that. Now, when paraprofessionals come in, this is where you may start to see the cracks in teams and things like that, because they get very frustrated thinking that somebody's lying or trying to get one over. So focus on the function of behavior instead of what they're trying to, that it's just manipulation, that it's just a function in and of itself. And so what percentage of cases are actually correctly classified as malingering? It says around 8% of general evaluations and 20%. It's just saying we got a lot of work if we want to correctly identify the people that are malingering. It makes sense. We tend to overdo, and the correct, we look at what was correct, and we get to these numbers. So Boone points out that it is exceptionally difficult to arrive at an objectively based discrimination between externally motivated malingering and internally motivated somatoform disorder. It makes sense to me. If you have undifferentiated somatoform disorder, you've got these vague symptoms sometimes, some lethargy in there with it, and it would be very difficult to say, is the person faking or are they telling the truth? And also, you were talking about PTSD a minute ago. There are very high rates of somatoform disorder with PTSD. And so sometimes when people are talking about these things and they think that they're just reaching for service connection, they may be actually talking about the confirmation of diagnosis, the one that's very frequently, and some studies actually indicate the most commonly diagnosed comorbid disorder with PTSD. And people say, well, they're faking that, so therefore they must be faking PTSD, when in actuality, the thing that they're talking about that they say that they're faking would be confirmation of, or more evidence of at least, that somebody might have post-traumatic stress disorder. So they point out, given the severe consequences, and Dr. Hayel was talking about this a moment ago, of determination of malingering, meaning circumstances, civil, criminal, legal allegations or actions, it seems undesirable to base this relevant criteria solely on clinical judgment, which has been found unreliable in most studies as far as accuracy rates. This is one where they examine the cognitive processes of both mental health professionals and the subtle biases that influence their decisions. Sometimes I go back to Psych 101, where Rosenberg did the study initially with, it was at Harvard, they did it with mice, and they had told the students that some mice were smarter than other mice. They weren't. They were just both the same mice. But the students who were informed that the mice were smarter actually started to have faster maze times for the mice that were running. They were starting to do things that would bias how they were actually measuring the performance of mice. And then they did this also in school kids. You know, you have some school kids, they said that they came in, they pretended to test. These kids are really smart. These kids not so much. And so when the smart kids interrupt, they are intellectually motivated. And when the ones that were more typical interrupted, they were just incorrigible. And it goes on and on. Our biases can start to slip in on these things. Another study by Zimmerman, recent research raised concerns about the adequacy of psychiatric diagnostic evaluations conducted in routine clinical practice. Semi-structured diagnostic interviews have been considered now the diagnostic gold standard, but we have tests that can go even further. Judged against the standard, studies comparing unstructured clinical interviews with the semi-structured found that there's a high rate of misdiagnoses using the usual clinical assessment. Now, part of the reason for this slide is going back over here. You're looking at about 1980, and they're just talking about the amount of research that was done in malingering then. And we're using the same criteria even though the research has exploded. We know so much more about it. We know so much more about trying to look at function, that multidimensional approach. But yet we're still using a lot of the same criteria that we've always used since that time. So I like that interview and assessment. I think psychiatrists and psychologists are great at interviewing people. I think I'm amazed sometimes at what you guys get in just a short interview. It never fails to impress me what my colleagues seem to be able to extract in a short period of time. And when I'm starting to look at these things, we look at the assessment piece, and as it says here, you've got rare symptoms, quasi-rare, improbable symptoms, and it gives you a list, and you can look these up afterwards, but it gives a list of the different types of tests you can use to see which one of these are. You see the SIRS in there a lot, and you see the SIRS used to validate other instruments a lot. And I'll briefly talk about it as well. The MFAST is the Miller Forensic Assessment of Symptoms test. Now, with the MFAST, part of the reason they like to use that little acronym is it's quick. You know, 10, 15 minutes, you're done with it. One of the problems I found when I've used this instrument is if the person is a particularly sophisticated person or a particularly sophisticated sociopath, you can definitely, they kind of catch on, is what I've noticed. They start to either become evasive or just shut down. But it works well when it works, and it does give these different reported versus observed symptoms, and that's also on the SIRS. somebody can report, they say, I'm so nervous I can't sit still. And then you're prompted to look every so often to see if they're sitting still, and they are. And so you have to mark that. Extreme symptomatology, which the MMPI also uses a lot. Rare combinations. I also look at, as I mentioned a moment ago, common combinations. Sometimes people don't know to fake certain symptoms or other diagnoses with a diagnosis. And so I find it very interesting when people report something and then have the opposite or absence of something that almost always goes with it. Unusual hallucinations, unusual symptom course, negative image or suggestibility, which is also used on the SIRS. Can you suggest things and they start to pick up on it? So it's 25 items, 5 to 10 minutes. 10 minutes to score. They don't have to be able to read, you just say it to them. And it was developed using both the known group and simulated studies. A lot of the studies have where you ask people to fake an illness or fake certain things to see if we can pick up on it. People, be students or anything like that. The structured interview of reported symptoms really kind of, and there's a SIRS 2 now, and it's really probably the gold standard in many people who work in the field in their opinion. The initial development was based on exhaustive review of potential detection strategies of feigned mental disorders. This one's a little more complicated to give. It's not difficult. It's just, there's a lot of check, recheck, re-asking of questions. Sometimes it can bring forth some suspiciousness from the person. The MMPI does the same thing. They'll finish it and they'll go, it was asking me the same question 4 times. Why was it doing that? And I tell them sometimes, I say it's just making sure that you're being consistent, that you're just saying the same thing across the way. Final item selection was based on independent judgments by 8 experts. Malingering was subsequently refined to improve its homogeneity, and the SIRS was composed of 173 items that are organized by 8 scales. And I'm going to skip through some of this part just for a second. You can see, well, let me go back real quick. You can see they relied heavily on the inpatients and correctional settings as well, forensic settings as well. And there's your different ones again. The rare symptoms, symptom combinations, improbable or absurd symptoms, blatant symptoms, subtle symptoms, selectivity of symptoms, severity of symptoms, and reported versus observed. Now, severity of symptoms is something that the MMPI also uses, and I'm giving you some precursor to that as I approach it to save a little bit of time. But the MMPI looks at a lot how severe are the symptoms, and they have things that will pick up on that. Let me go back real quick to this. This had good internal consistencies. It was very reliable, which means it's just shown to be measuring what it's supposed to, and it's replicated across different settings. And then the major focal point of the SIRS is its discriminant validity, which means it can tell the difference between somebody who's faking and somebody who's not. Now, the MMPI is the 567 item personality inventory. When people hear that number, they're like, wow. When I tell them it takes 45 minutes to an hour to take, it often is much more approachable as far as that goes. The first 370 questions give us our clinical scales, but they also give us some of these validity scales. Now, the infrequency scale is the one that's often talked about, if I can do that, there it is. It's often talked about as the one that picks up on malingering. More recent studies show it can do that, especially it gets into these extreme scores. Once you start to approach 100 on that scale, 110, it's often considered invalid. The last scale is, yes, 5 minutes. Any questions? No, I'm just kidding. I'm going to finish up one thing real fast. So the last scale here, and I want to show you what I like about the MMPI. Last scale isn't necessarily checking about lying. It's seeing about people who lie to look good. It's more like, I want to look like I'm doing better than I'm looking. You can imagine if somebody's in the hospital against their will, why they might choose that. I'll skip Grin and Trend to stick with these F scales. Once you get past 370, you're into the F back. It's looking for the same thing. Extreme, like even the most severe people who have psychiatric disorders are not approaching these scores. And when we get to FP, it becomes a very important one because FP actually is for malingering. And once we get there and it's approaching, I'm not even going to worry about that part. I can just do it from memory. Once F and F back are approaching 100, or if they get to 100, once FP gets up to about 75, 80, you can definitely say somebody's exaggerating big time. If the FP score gets to 100 with F and F back over 100, the most recent handbook on the MMPI says that is someone who's faking at a predictive value of 1.0, meaning it's just almost a perfect correlation to somebody who's malingering. And I had a guy one time, I did some testing on him, and I really didn't want to report that. And when he came in and I was trying to talk to him about it, and I said it, he said, well, that's not in your report. And I was like, well, it's in there. I said there was some exaggeration. And I want it the way you just said it, that I'm malingering. And I was like, okay, if that's what you want, we can arrange that. But when you take that kind of assessment, you have that kind of information, you take the interview, you do that, then you start getting into an area where you can have a powerful kind of thing. It helps get the team together, it helps get paraprofessionals on board, and it makes you feel more confident about your treatments. Any questions now? Anybody? Yes?
Do we dare to make this diagnosis? Because are we labeling? That's one thing. But I think it's important to have a track record of behavior that's repetitious of this to then support that this may in fact be malingering that's happening in order to ultimately be able to make that as a diagnosis. Yes, it's a V code. Yes, it may not get paid. There's a lot of insurance implications, whatever else as well around that. But I do think it's important that we teach trainees that they do need to assess for that, and they do need to be able to make such a diagnosis.
That's true. I'm not against the making that diagnosis, but what I see is happening, for example, a patient comes in and we already have a differential diagnosis, PTSD, major depressive disorder, severe, recurrent, and then at the bottom it is malingering. Are we treating the patient for the PTSD and major depressive disorder in the same time in order to get the coding right? And then we have the suspicious about the malingering. Which one is malingering? So what you said is correct. We need to be able to recognize it. But I think that would be better to be in a discharge summary. Some of those observations can be included in a documentation. If I have some concern about the symptoms that the patient is providing and I don't have any objective evidence, I can document it in my body of the note that this is raising concern for me. But putting it as a diagnosis, because that's the only part that the people usually look at it when they get the note. First they go scroll down and go to the, instead of reading the note. But we have that documentation tray for the next person to act on it if there is anything.
The repetition, I think you were
Yes.
talking about, yeah.
Well, that's the main thing that I have a concern about. This is my opinion. If I'm seeing a patient for 30 minutes in an ER, is it long enough observation that I can come to the conclusion of making that diagnosis? That's the part that I'm concerned about. So if someone comes in and they have a suicidal thought, this is depressed, and they're giving me all the information that I am concerned that this patient may have a major depressive disorder, and I'm concerned for the safety, I can rule out major depressive disorder because I'm not convinced, and put the patient in a hospital for the longer observation, and then we'll come up with the plan. But at the discharge, I may find out this patient is malingering, which is going to be on those.
I would agree with that. I think whenever I was at the VA, I worked there for almost 14 years. I ran a program over there that was 50 beds for severely psychiatrically ill. And there would be sometimes some concern that someone was malingering. You might see hints of it in the record, you might not. And I would say sometimes, well, we have the perfect program to observe them for the next 3 months to see if that's really what's going on. It gives us time to test. It gives us behavioral observations. We get to see if the consistency's there or not. And to the team's sometimes chagrin, I would say people would be like, oh gosh, so we're going to take a hit on this, aren't we? But what would surprise us many times, not sometimes, many times, is that the person was actually really telling what was going on, either subjectively, like somatoform disorder, or there was something going on. And they didn't turn out to be a behavior problem. Yes, sometimes they did, and the bias that we have is to pay attention only to those. Just like they ran a study over there one time and said we were always bringing the same people back in, but when they ran the actual data, only about 6% of the people were actually coming back into the DOM. But those are going to be 6% of the most ill people, and we will remember them because they're tough to treat. That's where the bias comes in. We have to fight that bias constantly. We have to humanize the person in front of us, for God's sakes. Don't personalize it. Objectify these things. Make sure we're using every bit of objective evidence that we have. It will make not only you a better clinician, it makes the care much better.
If you have a question about it, just give it the benefit of the doubt. So just let's try to observe it a little bit.
Yeah, even if I've got good evidence, I've sometimes put rule out. But if I put that word rule out malingering, there's going to be a big old chunk of my note warning the person who sees that note that they should be careful, that I'm not 100% certain about it, but there does seem to be a lot of evidence indicating it. It's something we can assess for. But I would be it would have to be overwhelming for me to go even to a rule out in an initial interview. I want my testing.
Yes. And that is your tools that you really can, if you are pretty much convinced with your clinical skill, then it doesn't hurt you if you send the patient to do the test. And I think that is the great thing that we had in a residential place when we were working together. Any other question? Comment? It's 6 minutes, but this is not correct time. Thank you so much.